just looking at those case history, I just wanted to ask
Maybe
her.
the first one, the timeline, isn't it?
Yes,
So
sir, from the
Sushmitha showed a
timeline. Yes, sir,
timeline.
from the timeline. I have it with me also, if I can share.
Yeah, the first slide.
Yeah. Yeah.
Second.
Yeah, come down to that stage, slide 3, now.
Slide 3. Slide 3.
Okay. Okay.
Yeah, this one.
See, ma'am, first thing is she was a 1998 born child. Fine. She was good for a gestational age. History of secretions from mouth. Probably you thought it was a meconium stain. But what is very interesting is the 2000, ma'am, that slide, at age when she was 2 years old, when this patient was 2 years old, there was an upper and lower limb rapid jerky movements lasting for 1 minute. And, this rapid jerky short lasting movement is not a coriform movement. Are we agreeing on that? Is that okay, ma'am, with you? The ma'am who's presenting the case, I'm sorry, I don't know her name.
Sushmitha.
Ma'am, Sushmitha, ma'am. Are you agreeing with that? In 2000, when she had these abnormal movements of upper limb and lower limb, which are rapid, jerky, and lasting for 1 minute, those are not coriform movements. Do you agree with me, or you concur? Huh?
Yes,
sorry?
sir. Maybe she is having a myoclonal jerks also.
Superb. So possibly it's a paroxysmal hyperkinetic, whatever, either it's a myoclonic jerk or it's a seizure. So there we have an issue. So it did not start with a hyperkinetic movement disorder, but rather it started like a seizure or a myoclonic jerks. And what was even more interesting was, see, when we come to 2001, I'm not sure whether we still call this choreoballistic. I'll tell you why, ma'am. I'll come to that. But you see the EEG over here, it says that there is an abnormal stage 2 sleep record with interictal discharges, which means there are 2 points that are being told here. One, that this patient is having a sleep disorder. And 2, this patient is having discharges in her sleep. Now, the first thing that we look at whenever we see an extrapyramidal movement disorder, be it tremor, be it chorea, be it athetosis, be it balismus, even dyskinesias to some extent, most of them disappear during sleep. This is something that is very nice. Imagine a choreic patient who is also choreic during the sleep. It doesn't happen. It happens when the patient is awake and not during sleep. So this is something that is striking me. Why is this patient having a sleep disturbance to start with? Why was there an abnormal stage 2 sleep in this patient? And why was there an interictal discharges? Because I'll tell you why, ma'am. It is very, very rare to see a choreiform disorder with a seizure disorder in a child who is probably 2 years old. You're getting what I'm saying? So the neuro insult has started somewhere that early, and it was a seizure and a sleep disorder that had started first. And what was more important was this patient was started on valproate, and the patient actually started improving. So 2001 to 2005, they took it and then stopped the ADs, which means whatever myoclonic jerks or whatever seizure she was having was very well responding to sodium valproate, which is well known. So you have a sodium valproate that was given, and her myoclonic jerks or whatever had disappeared, and to some extent her sleep cycle disappeared. But look at this, ma'am. Again, after stopping the AEDs, she had similar episodes in the mornings, and you have written very simple or very clear words. Early mornings preceded by brief arousal from sleep on prolonged standing. Why is it related to sleep, ma'am? That is what is very striking for me. Very rarely you get these kind of disorders and symptoms that are related to sleep. Nobody describes a choreiform or athetosis or balismic movements related to sleep. Just after waking up, the patient had it, or just before going to sleep, the patient had it. Myoclonic jerks, yes. Seizures, yes. We have seen this. We have had these frontal lobe seizures or seizures that happen during sleep. They are paroxysmal events. So whenever we are describing a movement disorder, no ma'am, we divide it as paroxysmal, continual, and continuous. These are the 3 ways we say. And whatever your description of chorea, it is not a paroxysmal event, ma'am. It is usually a continual event. When you're seeing the patient, when the patient is awake, the choreic movements will keep happening. But if you're saying it is paroxysmal, then we'll have to think whether are we really dealing with a choreiform movement, or it is probably a choreo-dyskinetic movement or a dystonic kind of movement that is coming in. Why that is important is because then the diagnosis changes. And also our treatment strategy could change. Can you go to the next slide, ma'am, if you don't mind? Yeah. So 2011, you had started on tetrabenazine, sodium valproate, and continued to have the same similar episodes, and all that is fine. And then she was MRI was normal, history of trauma to limbs, okay. Started on Ayurvedic medicines, all that agreed. Then she went to 2018 to NIMS. KF ring was done. Okay, ma'am. Next slide, ma'am. Sorry, please. Okay, Oxford. And again, same thing. Video EEG showing favor of paroxysmal hypnagogic choreoathetosis. I would like you to Google search this, ma'am. Hypnagogic choreoathetosis is such a rare diagnosis, or such a rare event. Why should this choreoathetotic be related to the sleep? I don't have an answer to that question, but it also gives me an option to look at treatment strategies. What happens if we are regularizing this patient's sleep cycle? If we regularize the sleep cycle, maybe this patient doesn't have these frequent arousals in the night or this improper sleep cycles, then maybe this choreoathetosis would settle. Because it is very, you mentioned in your presentation, ma'am, that the choreoathetotic movement in this patient or the choreoballistic movement in this patient was present around 20 to 25 episodes per day. Correct? Am I right, ma'am? You mentioned that, right?
Yes, sir.
Yes. Now,
Yes,
which
sir.
means that it is paroxysmal. I'm sure you would have seen hypoglycemic choreas, hyperglycemic choreas, chorea gravidariums, SLE choreas. They are continuous. The patient is always wriggling, fidgeting, and all that. Why should it occur in bursts? Why should a choreiform movement occur in bursts? That is what is telling me that this is probably because those movements are so upfront in front, like we are seeing it so obviously. Probably we are missing out something else. We are missing out the dystonias. We are probably missing out her sleep cycles and all that, because maybe that is also a treatment strategy which we could look at. This is what I felt in this case, ma'am, because this is a patient who has been having probably a perinatal insult, and then patient had a seizure to start with, myoclonic jerks. You had stage 2 sleep disorder that was documented. Then the seizures got settled, or the myoclonic jerks got settled in sodium valproate, and then she presented with a paroxysmal hyperkinetic movement disorder, which resembles a choreobalismus. But the definition of a choreoballistic movement is that it is usually continual. It doesn't come in paroxysmal bursts. And if it is coming, because can you show me the picture, ma'am? Can you show me the picture down? The picture of her hand and feet. Yes. Now, can you go back to the video, ma'am?
Video.
Yes, ma'am, the video.
The previous slide. The
Video.
previous slide,
Yeah.
I think.
Video.
The 6th one was the video. This patient, you couldn't keep the hands and feet like that and take a picture, ma'am. It would have been very difficult. Am I right? Meaning, this is what I'm interpreting, ma'am. This is whatever you have given me. I'm sorry if I'm, using only what you have given. That's not so unfair on you, because you would have seen the patient throughout. For this kind of movement, and suddenly you have a patient, you say, hands, keep your hands together, let me take a photo, legs together, keep me a photo. And for this kind of choreoballistic movement, it is very difficult to take, unless you have taken this during sleep. So why are these even paroxysmal is the question, ma'am. That is why this case is intriguing me. If we do a sleep study on this patient and maybe look into her REM and non-REM sleep patterns, and probably if you're able to correct that, maybe her movements will come down. Apart from the tetrabenazines, the sodium valproates, and all that you are giving, this is what I would feel will help in the case. I mean, chorea is a symptom. It's good to have that symptom. The type of chorea, except maybe if it is hemichorea, most of the time it doesn't differentiate in the clinical diagnosis. Like you won't have a chorea gravidarium presenting completely different from, let us say, an SLE induced chorea. You are going to have that, just like fever. But it is the associated features of chorea that is going to help us. Like rightly ma'am said before us, like if you had put the pedigree and all that, and the clinical examination findings, the same way, how is this chorea paroxysmal? That is what is striking me in this case. Why should it be paroxysmal? Why is it sleep related? And finally, that Ayurvedic medications, you said it's working. That's also mind blowing. Like, what Ayurvedic medicines works for chorea, I don't know. But if you're saying that the symptoms have come down, that means there's something in the drug or the natural course of the diseases in such a way that probably, the choreiform movements have started settling. I will not go with the diagnosis of benign chorea, or I won't even go with the diagnosis of Sydenham's, ma'am. This is something that is more, it's a complex movement disorder, maybe also related to sleep cycles. The closest thing I could see where you had a seizure plus a coriform movement plus sleep disorders is a Huntington's like diseases. There are 3-4 diseases under that category, but that required genetic testing. Since it was, she had an insult in the perinatal period, maybe there is something structurally wrong also, but obviously your MRI is normal as per your reports. But this is where I would look at this case, ma'am. It is very intriguing, and if I was a treating physician, I would try to regularize her sleep and see what happens to this coriform movements, ma'am.
Okay, sir.
I think
these are
those are my comments.
really thought-provoking inputs, Kaushik. So
Yes, sir, because
actually,
how
we
is
haven't
this?
thought about it this way. So it's really very interesting that you pointed out. In fact, we just Googled it and jumped to benign chorea because we felt that was fitting into it. And
Because
then
these the benign part of that chorea is, no sir, from whatever I understand, it's a benign. When you use the word benign, it means it's not a serious disease, which means this kind of high movement, this kind of injury should not happen. I'm most worried about these diagnoses, sir, because whenever some big institutions makes these diagnoses, no sir, on follow up those diagnoses remain, and very seldom we go back and recheck whether we need to revisit those diagnoses. And after that, these patients are lost, sir.
Yeah. In fact, that's one of the golden rules of clinical problem solving. Revisit the scene of the crime. Sherlock Holmes. So, yes. So,
doctor, if I
you
might,
have made us revisit, rethink this case from a new light. And yeah, that's a possibility. I mean, we just took a shortcut and thought it was benign chorea and it's not getting controlled. But you pointed out the interesting part that it was not continuous and it was coming in paroxysms.
yes, sir.
Which,
And
now
chorea
that you
is
tell
not.
us, yeah, now that you tell us it does seem to be very convincing that yes, why should it be paroxysmal?
There is one. Can I slide? Can I share my screen, sir? Is that okay with you?
Sure, absolutely. Please.
Okay. Is my screen visible?
Not yet. Just see if the screen from that end is visible. I mean, can be made visible.
Yeah. Can you see mine, sir?
Yeah, we can see it now.
So when we go to this approach to hyperkinetic movement disorders, no, sir. So the first thing is that there are so many hyperkinetic movements, and it's pretty confusing. So the easiest way we see is we looked at your observation of these hyperkinetic. You divide it into immediate impressions, more prolonged observation, and some things that require a longer observation. I will just go through a few of them, sir. For immediate impressions, you should define your movements as whether it is rhythmic or arrhythmic, sustained versus non-sustained, paroxysmal versus continuous, and sleep versus awake. So supposing if you see rhythmic hyperkinetic, it is tremors, dystonia, myarrhythmia, all that. Not dystonia, sorry, dystonic tremors. Irregular is your myoclonus, polymini myoclonus, cortical myoclonus, and arrhythmic is chorea, thetosis, balismus, and all that. Then we see whether it is sustained or ill-sustained. Sustained is usually rigidity, dystonia, paroxysmal dystonia, and all that. And then this is the part, paroxysmal versus continuous. So a continual means over and over again, and continuous means without stopping. Tremor is a continuous movement, whereas your balismus and chorea are continual movement. Whereas paroxysmal occurs at times and then stops. That is why I'm saying, are we dealing with a dystonic hyperkinetic movement disorder rather than a choreic kind of movement, where there is a difference between a continual and a paroxysmal movement? And what are the movements that appear during sleep and disappears when awake? What are the ones that persist during sleep? And what are the ones that diminishes during sleep? So in this case, if you see periodic movements in sleep, REM sleep behavioral disorder, all that appears during sleep and disappears when awake. And persists during sleep are very few movement disorders. why is the sleep cycle related to her hyperkinetic movement disorder? That is what I would really go into. But I would suggest that, sir, it's a big way to approach this hyperkinetic movement disorder. There are other slides as well. But what I would harp on is, sir, chorea is a very visually engaging symptom. And when we see that, we tend to overlook other things because that is the one that is obvious. That's the elephant in the room. But I think we should keep that aside and look for what else is being associated with this chorea. And if we are able to describe that, maybe we will be able to reach the diagnosis better, sir.
Yeah, that's really quite an eye opener. Yeah, so Dr. Sharanya here wants to ask something.
Good afternoon, everyone. So not exactly regarding this case, but related to this, I would just want to know that we just discussed that there can be some hyperkinetic movement disorders which may disappear during sleep. We have just seen another patient who was a middle-aged lady. So she presented with flinging kind of movements in one of her upper limb. But what we saw in her is she was kind of concentrating on her upper limb, which was showing the movement. And when we were trying to divert her, the movements were almost disappearing. And also she had some passive symptoms like that of which were pointing towards a depressive kind of attitude, like no eye movement,